So, dear participants, my name is Dr. Julia Zając, and I have a great pleasure to welcome you at the 7th EuroBloodNet Topic on Focus Cutaneous Lymphoma webinar. Before we start, please mute your microphone and switch off your cameras to maintain better streaming quality. And please make sure you entered your full name and surname in WebEx because it's very important for receiving the educational points after attending the whole cycle of webinars. If you have any questions about the presentation, please write it in the chat because at the end there will be a discussion. And dear audience, please welcome with me today's two speakers, Professor Beylot Barry and Anne Pham-Ledard, who will tell us about primary cutaneous large B-cell lymphoma, leg type. Professor Beylot Barry is the head of Department of Dermatology at the University Hospital of Bordeaux. She's a member of the INSERM Unit of Oncogenesis of Cutaneous Lymphomas team, where she leads national trials and international collaborations. She's the General Secretary of the French Group for the Study of Cutaneous Lymphomas. She has twice coordinated a European course on cutaneous lymphomas with the support of the EADV. She's involved in teaching dermatology with a strong focus on surgical dermatology and was a president of French College of Teachers in Dermatology. Within the French Society of Dermatology, which she is currently a president of, she has been for several years a member of the board of directors, a member then a president of the scientific council, and involved in the fund of research of the French Society of Dermatology. Moreover, Professor Beylot Barry is an author of more than 300 publications. Professor Dr. Anne Pham-Ledard is a specialist in cutaneous lymphomas, working at the Department of Dermatology at the University Hospital of Bordeaux. Professor Pham-Ledard has completed medical school in Nantes, France, then moved to Bordeaux for residency in 2005. During her training, she has done a master's degree and PhD in the research team working on cutaneous lymphomas, oncogenesis, mentored by Professor Beylot Barry. She moved for her postdoc position to Southampton, UK, where she worked on modelization of cutaneous B-cell lymphomas, microenvironment, and immunotherapy in mouse model. Professor Pham-Ledard has been working as a professor in dermatology since 2018. The microphone is yours.
Thank you, Julia. So it's a pleasure for me to participate to this webinar on cutaneous lymphoma, especially on the primary cutaneous large B-cell lymphoma leg type. That is an important topic for our team. So here my conflict of interest on cutaneous lymphoma. So the beginning of the story was in Leiden with this well-characterized series of 18 patients, advanced age patients, most of them were female, with lesion on the legs and intermediate survival with a 5-year survival of 58%. The histology showed large cells, round cells, immunoblast or centroblast. This was confirmed in the series of the French group of 60 cases several years after, with a similar population, similar 5-year survival, and the prognostic factor identified were age, multiple lesion, leg localization, and ulceration. Here you can see a very suggestive clinical presentation, an advanced age woman with a tumor on the right leg that appear rapidly. That is important to consider this rapid evolution that is very suggestive of this lymphoma. However, you can have some unusual presentation, such as this that has been published and we observe also in our patients, with a patch or plaques, either at initial presentation or when the patient recurs. The infiltrate may be superficial or deep, as in this patient. When you perform the biopsy, of course, you have to perform a deep biopsy because the infiltrate spares the epidermis and is in the dermis and hypodermis with this large cell, atypical cell, immunoblast or cytoblast. And the typical expression profile is BCL2 and FOXP1 positive, MUM1 positive, CD10 is negative, BCL6 may be positive or not, and there is frequently a high proliferative index. So this kind of lymphoma, leg type, represents 15 to 20% of cutaneous lymphoma and has very different prognosis. You can see on this survival curve, comparing to primary cutaneous marginal zone lymphoma and primary cutaneous follicular central lymphoma, with frequent recurrences in the skin, but also in extracutaneous spreading in nodes, central nervous system. So an adequate diagnosis is crucial for an adapted treatment. However, this diagnosis may be challenging for pathologists. Indeed, it's not with marginal zone lymphoma, with primary cutaneous follicular lymphoma with small cell, but with some cutaneous follicular central lymphoma with large cell. Typically, cells are cleaved cells, but that may be difficult to distinguish them from a large cell of leg types that are typically round cells. And the phenotype analysis is therefore very important for the differential diagnosis. And our team has investigated which markers are most relevant for differential diagnosis. And as you can see here, for the diagnosis of leg type, MUM1 expression and FOXP1 expression was the more relevant marker for their positivity, while CD10 was negative and follicular dendritic network CD21 was negative. BCL2 was not a very discriminant marker between the two entities, as well as BCL6. Of course, you have the histology, the phenotype, but also the clinics. That is very important. I come back to the clinics, and you can have a typical presentation of this lesion follicular center on the trunk, and here a leg type on the leg. But you can have a leg type on the trunk and follicular center on the leg. And an important point is the kinetics of the lymphoma with a slowly progressive evolution in follicular center and mostly rapid evolution in leg type. So after the diagnosis, the staging for the clinical evaluation, first for the skin extension that have above all an impact on the prognosis. And you will use the TNM classification for a lymphoma other than MFSS, with T1 for solitary lesion, T2 for regional skin involvement, and T3 for diffuse skin involvement. Most of the patients with leg type will present a diagnosis with solitary lesion on regional skin lesion. It is rare to see the patient at diagnosis with diffuse skin involvement. After a clinical examination of the skin, you have to check the nodes, of course. The general status, it will be important for the therapy choice. Blood test, especially lactate dehydrogenase, the result of skin biopsy, of course. The molecular analysis of the skin biopsy, you can perform a PCR for EGH rearrangements that will have mostly an interest for the staging to have a reference point. And the MYD88 mutation is important to be searched because it is an important diagnostic marker. I will discuss this in some slides. For the imaging, you will perform a total body CT scan to be sure that is a primary cutaneous lymphoma, but you can also perform a cerebral CT scan because some patients can have recurrences in the brain, and it will be important to have an initial point of the CT scan in the brain. The PET scan is very useful, especially in patients who have several skin lesions, especially subcutaneous lesions, for the initial staging, but also for monitoring tumor response. For the bone marrow biopsy, it is recommended for intermediate and aggressive primary cutaneous B-cell lymphoma according to the guidelines. However, in my opinion, this is debatable because it has not clearly an impact on the patient management, and in our experience, we do not perform this exam in these advanced age patients. So how to treat this patient? There are some limits to therapeutic guidelines because they are largely based on retrospective study and institutional experience. There is no randomized and controlled trial, but we have a large retrospective comparative analysis and one phase 2 study that I will present. The second limit is due to the patient, advanced age patient with a poor prognosis and high risk of recurrences and extracutaneous spreading. In the early 2000s, hematologists have demonstrated that the regimen that associates rituximab and CHOP will provide interesting results and good results in comparison with CHOP chemotherapy in elderly patients. So what about primary cutaneous lymphoma leg type? This was the aim of this study conducted by Florent Grange in the French group of cutaneous lymphoma, and we analyzed the specific survival in 115 French patients with leg type lymphoma according to the period of diagnosis, before or after 2003. And we observed an improvement of survival, as you can see here, between the two periods. When you look to the two periods, you can see that the patients in the period 1 were mostly treated by radiotherapy, while in the period 2, they were mostly treated by chemo. When we looked further to the treatment, you can see here that the best results were observed with patients who received rituximab and polychemo. You can see here a 5-year specific survival. And this treatment overcomes the negative effect of typical adverse prognostic factors, such as leg location and extent of skin lesions. So we have to consider in first line in leg type lymphoma this treatment in our patients if they can receive it, because it has been demonstrated to improve survival. However, we have advanced age patients, and sometimes we have to use age-adapted regimens without anthracycline or with mini-CHOP, or perhaps to perform less cycles of chemotherapy, and after to perform radiotherapy. I will discuss this in the next slide. Some publication has also discussed in isolated case other alternative associations such as rituximab and liposomal doxorubicin that has less cardiotoxicity. You have to notice that rituximab monotherapy only allows short-term response. In all these patients, you have, of course, not to forget the supportive care, gastric protection, hematopoietic growth factors, and infectious prevention that because you may have sepsis who led to the death of the patient. Some word about radiotherapy. If you use radiotherapy without rituximab and chemo, it has only a palliative effect with frequent relapse and short-term relapse. If you use the radiotherapy associated with rituximab and chemotherapy, you have to remember that there is no trial that demonstrates the interest of the association in primary cutaneous lymphoma. Even it is recommended in recent guidelines after chemo, after 3 cycles or 6 cycles of chemo. In our experience, we perform radiotherapy in some selected case, refractory case, who have a partial response after systemic chemo. You have to know also that recurrences may be seen on treated but also untreated area. However, even after chemo, we can observe still recurrences in our patients. And then the therapeutic choice is very complicated in already treated patients, advanced age patients with some comorbidities. So we need new therapeutic options and strategies, and also predictive marker for response and recurrence. And this part will be discussed in the presentation of Anne. I want to say some word about gene expression for profiling in diffuse large B-cell lymphoma. It has been demonstrated that there are two main subtypes, germinal center and activated B-cell lymphoma. ABC lymphoma have worse prognosis and constitutive NF-kappa B activation. They may be identified by a transcriptomic analysis, but also by a phenotypic analysis. And primary cutaneous B-cell lymphoma leg type have demonstrated that they have an ABC type profile. Several advances in biological knowledge are now available for these recent years in leg type lymphoma, especially MYD88 mutation, that is a genetic feature recurrent in leg type lymphoma, as demonstrated by our team, with a diagnostic value, but also, as we demonstrate in the French group series, a prognostic value. Other genetic alteration and somatic mutation have been demonstrated in these lymphoma that led for most of them to a constitutional activation of NF-kappa B pathway. Lenalidomide may be a candidate in this lymphoma. Why? Because it interacts with NF-kappa B pathway with an inhibitor activity, and has also an activity on immunity and anti-angiogenic activity. We have this paper, for example, that have demonstrated promising results with lenalidomide in systemic large B-cell lymphoma, especially in ABC type. And we have also some isolated cases with lenalidomide that obtain in primary cutaneous lymphoma leg type a short-term remission. This led us to conduct a single-arm phase 2 study with lenalidomide in patients who have relapsing or refractory leg type lymphoma after ER chemo. We use lenalidomide with 25 milligrams daily, and we included 19 patients, advanced age, you can see, until 92 years old. Most of them have a lesion on the leg and have a T2 stage. We observe a 63% of overall response, but according to our primary endpoint, we have a response rate at 6 months of only 26.3% of case, but including 4 complete response and 1 partial response. And at 12 months, we have 3 still treated with 2 CR and 1 PR. The median PFS was of 5 months, but you can see that we have also long-term PFS, as you can see here in this curve, with not so bad overall survival in such relapsing and refractory patients. We have also severe adverse events, and we have to reduce the dose due to adverse events in 7 patients, especially cytopenia and thromboembolic events. So the conclusion was that we observe a response in limited cases, but we can observe a prolonged response, and especially the patient who respond after 6 months, they may have a durable response after 12 months. And we observe better results when we reduce the dose, and this allows higher number of cycles, and finally a better survival. This led us to conclude that maybe reduced dosage has to be used in such patients with leg type lymphoma. Perhaps the association with rituximab has to be investigated, and Anne will speak about this later. We have perhaps to discuss in selected patients maintenance therapy after ER chemo, as it has been proposed in systemic lymphoma. and we have to choose which patients we have to treat with such approach. To go further, we need to investigate all this pathway and perhaps to have different drugs that will cooperate in these different pathways. This will be one of the subject of the presentation of Anne, and also perhaps to target microenvironments that may be useful in this lymphoma. So I want to finish with some acknowledgements to the French group, of course, to my team in the hospital, to my team in university, to the team the team of Fabrice Jardin in Rouen, and of course EuroBloodNet. Thank you for your attention, and now it will be Anne.
Hello, everybody. Thank you for the nice introduction and for Marie for the first part of the speech. So here are my conflict of interest. And I move on about the therapeutic recommendation. As said by Marie just before, we know that the first-line therapy has to be rituximab plus polychemotherapy in the patient that are able to receive that with good general condition. In refractory or relapsing case, we are still in difficulty with which therapy to choose for them. We know that radiotherapy has only a palliative effect. Second-line chemo is usually difficult and not so effective, and other targeted therapies may be interesting. I start with an example of this clinical case. Old woman presenting with a tumor on the knee. She had 6 cycles of air chop with a complete response, but a very quick cutaneous relapse on the leg 3 months later. And because she was in good general condition, we chose to perform a second-line chemo with rituximab plus gemcitabine and oxaliplatin. But the clinical response was poor. The chemo impaired her quality of life with side effects, and the lymphoma occurred with a diffuse infiltration of the foot. So it is mandatory to understand the genomic landscape of this disease, oncogenesis mechanism, to develop new therapies for these specific patients. As Marie said before, the leg-type lymphoma exhibits the same features as activated B cell or ABC DLBCL, with transcriptomic profile and also immunophenotype consistent with ABC profile. Also, the immunoglobulin gene analysis is consistent with this post-germinal center profile as demonstrated in this paper. About the classic oncogene alteration that are seen, they are finally the same that those observed in ABC-DLBCL, with very frequent P16 deletion, some MYC translocation, BCL6 translocation, and usually no BCL2 rearrangement. About MYC translocation, the literature is controversial, with in this paper from Leiden, about 1/3 of patients harboring MYC translocation and a reduced specific survival found in this subtype of patient, while in our study, these translocation of MYC are very rare, less than 20% of patients, and no impact on prognosis. About double hit that are finally both BCL2 translocation and MYC translocation, as seen in some systemic DLBCL, they are very rare, and it is we think that it's not usual to useful to search that in those patients. About the expression of BCL2 and MYC, it is very frequent that leg-type lymphoma harbor a dual expressor profile with both BCL2 and MYC expression. And here we have shown that the specific survival is better in patients without this profile with double expression. To move about BCL2, I show you this single case report about the BCL2 inhibitor venetoclax targeted therapy. It is a drug that have shown efficacy in CLL. And in this case of leg-type lymphoma, you can see the nice clinical response, also seen on the PET-CT. In this case, with no BCL2 mutation or amplification, BCL2 strong expression, and about the genetic profile, this case did not harbor any MYD88 mutation. About the next generation sequencing, two main papers have been published in late-type lymphoma. This one from our team done in collaboration with Fabrice Jardin team in Rouen, who leads the genetic analysis on systemic DLBCL in France, and the second one from this team. About the NGS profile, we confirm that MYD88 mutation is very frequent, with 60 to 70% of patients having this mutation. We found also other genes involved in NF-kappa B pathway mutated, as PIM1, CD79B, or TL1XR1 mutation. All other genes were also sometimes implicated, and I will not tell you all the list. Finally, if you compare the targeted NGS of leg type to other subtypes of DLBCL, especially a primary central nervous system lymphoma, shown here, you can see that leg type lymphoma mutational profile is very close to central nervous system and closer than other DLBCL subtypes, with high frequency of MYD88 mutation in both. Also, PIM1 mutation very frequent, BCR pathway mutation, and TBL1XL1. This second paper about NGS in leg type did confirm that MYD88 mutation is very frequent in this second series of patients. Did found also that BCR or NF-kappa B activating gene were implicated in the disease. They also found that gene implicated in immune surveillance were sometimes mutated as CD58 or MHC class 2 or class 1, for example. To sum up, you can see the main mutation that can be found in leg type. Here, the toll-like receptor pathway, and especially MYD88, very frequent. And here, the B-cell receptor pathway, and especially CD79B mutation, very frequent also, and more rare, the CARD11 mutation. We just wonder if finally the genetic profile of this patient may predict the clinics, and especially the complete response or the relapse or refractory disease. That's why we conducted this study and performed the targeted next generation sequencing with 36 genes involved in DLBCL pathway. We had the skin biopsy at diagnosis and two subgroups of patients. One, a first subgroup of patients with refractory or relapsing disease, and a second group of patients with good responders to rituximab plus air chemotherapy. In this work, you can see that on the top, the patient with a good response compared to the bottom here, the patient with relapsing or refractory disease. The CD79B or A or CARD11 that constitute the BCR mutation were more frequent in the bottom group, so in relapsing or refractory patients. If you consider the PFS or the specific survival, the results were confirmed with a patient with BCR alteration displaying a reduced specific survival in this study. And looking further in comparing the biopsy at diagnosis or at relapse in this patient, you can see that in some patients we saw an enrichment in some mutation, and especially this BCR mutation. Also, MYD88 mutation were enriched. So we think that this is in favor of a real impact of oncogenesis of this lymphoma in this patient. How to target these mutational profile is NGS analysis can help us to treat the patient. First, I would like to speak about BTK inhibitors. You can see here the BCR pathway, and BTK is this protein that can be targeted by a BTK inhibitor, leading to a reduction of NF-kappa B activity. BTK inhibitors are known in CLL, and in late-type lymphoma, some single case reports it does exist with a good response, but and sometimes not very long responses. In these cases, published by Lucy Fox, it is interesting because this case provides the genetic profile of the disease of this patient who had a response and then a refractory disease to ibrutinib. And they show that in this case, there were an enrichment of a CARD11 mutation explicating the resistance to ibrutinib. I show this clinical case of ours. It's a 65-year-old woman with a classical leg type with very thick plaque on the leg. CR obtained after 6 cycles of R-CHOP, but a very quick relapse, cutaneous on the same area, but around the first skin area involved. We put her because she was a poor general condition after the 6th R-CHOP. A second-line chemo was not indicated, so we proposed lenalidomide plus rituximab, but the disease was refractory to this regimen. So because of the NGS profile of this woman with MYD88 mutation and CD79B, we proposed ibrutinib, and since then, but only 3 or 4 months of therapy, she is now in complete response with ibrutinib therapy. What about lenalidomide? So you can see that lenalidomide can inhibit NF-kappa B through IRF4 or MEM1 activity. And lenalidomide is also known to provide immunomodulatory effects and also anti-angiogenic effects. So I will not speak again about the trial shown by Marie, showing good response in some patients, but not all of them. So we need to choose the patient that who will respond to lenalidomide. Here is a clinical case of mine, a very old patient with classical leg type lymphoma with skin tumors all around the leg. CR obtained after 6 cycles of R-CHOP, and then diffuse cutaneous relapse with patches on the leg, but also on the abdomen, and a tumor on the arm. The NGS mutational profile was MYD88 positive, PIM1. So we propose lenalidomide with a low dosage because of the advanced age, 10 mg per day, and associated to rituximab, and then only 10 days a month. So you can see that this patient has this therapy since more than 1 year with good response, not complete response, but minimal residual disease, only patches on the leg, no more lesion on the abdomen, and a very good safety profile. In systemic DLBCL, a new molecular classification has been proposed through exome and RNA-seq classification. And you can see that in ABC DLBCL, now some subcategories have been individualized, especially which interests us is MCD category with MYD88 plus CD79B mutated cases with an impact on survival, as you can see here, compared to other categories. And in this MCD patient, they showed that especially extranodal patients were represented, and especially central nervous system, again, a patient. So because we saw before that MYD88 plus CD79B were characteristic of a case of leg type, we could say that leg type belong to the MCD subtype. About this MCD subtype, so testicular or CNS DLBCL, some alteration of PDL1, PDL2 locus have been reported, amplification and translocation, leading to an expression of PDL1 or 2 proteins. Also in Hodgkin lymphoma, these proteins are expressed through amplification of the locus. And in this paper, you can see that these Hodgkin patients with PDL1-2 amplification did respond very well to a checkpoint inhibitor, nivolumab, anti-PD-1 antibody. That these data prompt us to look at our leg type cases and to perform the PDL1-2 rearrangement research by FISH. And we saw that some rearrangement does exist, even rare, only 2 cases out of this series. But in these 2 cases, this rearrangement led to a PDL2 expression by the tumor, not seen in all the other cases. And this study also allows us to see that the microenvironment of leg type was constituted of a lot of M2 tumor-associated macrophages marked by CD163 in red, and these macrophages did also express strongly PDL1, as you can see also here in a double immunohistochemistry figure. These rearrangements were confirmed by these authors, performing also a FISH in 10 cases, and they showed 4 positive cases with also tumor expression of PDL2 and or 1 in these cases, leading to the suggestion of perhaps immunotherapy in these cases. So what do we know about the checkpoint inhibitor in leg type? Not so much until now. In patients with PDL1-2 rearrangement, it could be interesting to block PD-1 with, for example, nivolumab or pembrolizumab, as it has been seen in DLBCL that the patient harboring such PDL1-2 rearrangement may respond better to a checkpoint inhibitor. Also, perhaps the microenvironment could be targeted through macrophage expression of PDL1. And this single cases is very nice, showing good clinical response after a combination of rituximab, lenalidomide, and pembrolizumab in this case. And it's interesting to see that it's possible that lenalidomide may enhance the efficacy of pembrolizumab through immune action on the cells and especially antigen presentation. To conclude, I would say again that leg-type lymphoma display typical clinical behavior and especially quick development. And the immunophenotyping is very important also. I would say that the much more important marker to me must be MUM1, strongly positive, and also FOXP1. I want to say also that in the last 10 years, some advances have been made in oncogenesis knowledge of this lymphoma, especially MYD88 mutation, very frequent. Also, other NF-kappa-B gene alteration and the importance of BCL receptor pathway. Also, the immunity gene involved, PD-L1, 2, and others may be important for therapy. And therapeutic perspective has still to be investigated because we still don't know for who, which patient, when, just after chemo maintenance or not, and how, which dosage, which protocol. The molecules would be, to me, lenalidomide, BTK inhibitor, other NF-kappa-B inhibitor may be interesting, and also perhaps checkpoint inhibitors. I would like to thank you for your attention and also to thank all my team, hospital research team, and especially my two mentors, Marie Beylot Barry and Jean-Philippe Mérieux. Happy to answer to your questions. So the question is the response to ibrutinib correlated with the presence of MYD88 mutation? So I don't have the exact answer. I would say that probably not. It has been shown that in vitro, the presence of both mutation of MYD88 plus CD79B is correlated in vitro to ibrutinib response. But in the patient themselves, I don't know. I would say that it's not a resistance mutation, but is it? I can't tell more. So we wait a little bit to see if there are some more questions. Thank you for your. Thank you.
I think it's very interesting to see the interest of NGS analysis in such refractory patients as you show with your clinical case. And I think that in the European group, it can be interesting to collect our case and to have a strategy, a common strategy in this patient. I think we will not conduct comparative trials, but more to evaluate strategies in this lymphoma. So you have a question, the response, how durable a response to ibrutinib in our experience? I think not so long. 6 months, I think, was the most longer response.
Yeah. So yeah, the patient I showed is a very recent patient. We don't have so much experience because we just we start some years ago, and we do not treat all patients with this therapy. But yeah, I think that some mechanism of resistance have been described, and that correspond that we see with some perhaps relapse after 4 to 6 months.
This was similar to systemic.
Yeah.
Yes.
Yeah.
Yes. The remark is so it's similar to systemic DLBCL. Yes, it's true.
Yeah.
So perhaps no in monotherapy.
Yeah. So the scheme of the administration have to be liberated with and trial would be interesting to answer these questions. So the question is, what are the risk factors for CNS relapse? So I let Marie answer.
We described recently in the French group 14 patients with CNS relapse without predictive factor, clinical and biological clinical factor associated. MYD88 was not a predictive factor, mutated or not. So not clearly identified still now.
No, it's just a single or two, perhaps two case experience. We had two patients, I think, with CNS relapse that had as neurological pain on the tumor. But it's just, a clinic observation.
So it is the question or the remark is, it is disappointing that primary cutaneous lymphoma types seem to be so similar genetically to systemic DLBCL. Are there marginal difference, do you think?
So my answer is that perhaps it could be disappointing, but perhaps these patients may be involved in a trial of systemic DLBCL because of that. But I would say it's interesting to have shown that in order to improve the therapy and the possibilities for our patient to go to clinical trials. And perhaps the difference would be about the microenvironment, because in leg-type lymphoma, we have no data about extensive analysis of microenvironment. And because it's the skin, because it is the leg, perhaps it could be different. But it's just an idea.
Any preliminary data with bortezomib?
So to my knowledge, not really.
Clinical case mainly.
I have already seen some DLBCL that had rather indolent course and therefore did not require an aggressive systemic therapy. Have you also made such observations?
I think that we have some patients with initial indolent course, especially this patient with patches rather than nodules and tumor. And in this patient, especially advanced age patient, we discuss, do we have really to treat them with air chemo? But in our experience, such patients secondly have a progressive disease with nodules and tumors. But perhaps these patients have to be identified and perhaps treated differently.
But they have, I think, about one or two patients with such patch presentation, and the genetic profile is the same.
Yes. So in our experience, we treated this patient with air chemo.
But we hesitate each time. It's a very difficult question.
The question is, how many patients are curable? We have some patients. I can say about half of the patients. I think.
Those who did not relapse after the first line, so yes. Half of the patients.
Well, 60% or 60%. I don't know, it's a similar experience in the audience. The problem is that they are advanced age patients and they may have a complication from the air chemo or for other comorbidity. So in the UK, how many? It is said not in the UK. So in the UK, how is the percentage? They mostly relapse. Not all.
But did you manage to provide all the cycles of chemo? Because I think it's important to go until the end of the chemo. And we have the experience of patient being with some asthenia, and we do the chemo, but with a reduction of the doses, or with some
with only 3 cycles and 0 labs.
We have we are currently looking at all our patients in a retrospective work. So we will tell you the exact answer, I hope, in these next months about the percentage of patients without relapse.
But when we publish the study with comparing the patients that relapse and patients who don't relapse, we have a similar number of patients in relapsing group and non-relapsing group. So if you could do a trial now with any all of the available agents, what will you do? I think that we will not treat the patient in the same way. We will have a strategy according to NGS results. I think that it will be the point to choose for some patient, perhaps rituximab and lenalidomide, for some other patient ibrutinib, perhaps for other patients immunotherapy. I think that we must have a strategy and not an a priori strategy.
Yeah, and I would add that probably the same personalized protocols as in DLBCL, because they have the same issues that we have, because they have the same genetic background. So we have to learn together with a hematologist to give the good therapy to the good patient.
But adapted to our patients. Because our patients are older and perhaps not exactly the same profile. Maintenance rituximab. It did not show an interest even in a systemic ABC lymphoma. So no. In follicular center lymphoma, yes, but not in ABC. Sorry, I will stop. But this is localized low volume disease. Yes, but it doesn't work and it will recur.
Thank you very much, Professor Beylot Barry and Professor Pham-Ledard, for this fantastic session today. And I would like to say also thank you for the audience for your participation. Before we go, I have some information. Please do not forget to fill in the survey we'll send to you after this webinar. It's especially important for the accreditation and receiving educational points. And I also have important information because the next webinar, the 14th of December, will be unfortunately the last session of this program, as due to some unexpected circumstances, we had to reschedule the last 9th session of Professor Stadler. We are truly sorry for that, but nevertheless, the lecture, the 14th of December, will be will combine 2 panels in one. So the content of the program will be maintained. So please remember, the 14th of December will be the last session of this program. To stay updated with all the information, I would like to invite you to subscribe to our newsletter. Follow us on Twitter, LinkedIn, and Facebook. And of course, please visit us at our EuroBloodNet's Edu YouTube channel, where we publish all the webinar sessions. Thank you very much. for attending today, and thank you, Professor Beylot Barry and Pham-Ledard, again for your great webinar session today.
Thank you, Julia. Thank you to the audience.